All right, we're starting off with just kind of a list of extras here. They don't really fall into specific categories, but we're just kind of rounding out the other special procedures. So we're going to cover fistulagram, sinogram, lubogram, a line check, and a scialogram rather quickly because these are not major ones, right? So fistulagram versus sinogram, they're similar but not the same. So a fistulagram is when there's a fistula, which is abnormal passageway between two anatomic areas. It could be between organs or between cavities or to the surface of the body. The sinus or the sinogram is an abnormal passage or cavity that originates or ends often on the skin. And so you can inject contrast material into either of these. So we'll start with fistulagram first. They involve the hollow organs, so usually in the intestines, bladder, urethra, vagina. They often result in infection or inflammation. Could be related to surgery, injury, or some post-radiation therapy. It could be a patient that has a history of Crohn's disease or ulcerative colitis because they have inflammatory bowel symptoms. Fistula locations, they can be in sort of a multitude of areas, but it could be between two loops of intestine. It could be between the anal canal. It could be involving the vagina, having a passageway to the colon, the rectum, the bladder. All of these things we don't want. So the contrast material will be injected into these to kind of gauge or identify where the passage is and the severity of it. So just going to give you a couple examples that you might hear wording-wise. So the Tracheoesophageal Fistula, which is abbreviated TEF, it's an abnormal connection in one or more places between the esophagus and the trachea. So as a result, swallowed liquids or food are easily aspirated or inhaled into the lungs. TEF is a birth defect. It is also commonly paired with esophageal atresia, where the esophagus does not connect to the lower esophagus in the stomach, and there is different variations of this, and so it can be a very concerning situation that they'll have to evaluate quickly. And so you may see in our pediatric fluoro area upper GIs for this. So they'll use some contrast and have them swallow and see where the connection is, or if the connection is not there, to evaluate it, as well as their ability to swallow and the diameter. So is it really tight in one area? Is it really dilated in one area? Things like that. There are two vaginal fistula types that we may see in radiology. And so the first one's the vesicovaginal fistula, between the urinary bladder and the vagina. It usually results in some abnormal discharge of urine through the vagina. Often the patients that I see presenting with this are history of hysterectomy and now having some complications. And so we'll do a cystogram. The contrast will be injected into the bladder. They'll do some obliques or some laterals, and we'll see if there's a fistula or a connection into where it's not supposed to be. The rectovaginal fistula is a fistula or a passageway that's formed between the rectum and the vagina. And this is where bowel contents could leak through the fistula and pass through the vagina. This type of patient would have a water-soluble BE to evaluate the colon and see if there is a fistula into the vagina. Operative fistulagram, which if you guys have been over to Chestnut OR, you've all probably seen one. And these are those AV fistulas usually. It's a surgical connection made between an artery and a vein. It's usually by the vascular specialist. It could be an arm or a leg. So don't be surprised if you go to a fistula and you've only done arms and you see them doing one in the leg. It is also possible. With the AV fistula, the blood flows from artery directly into the vein. The dialysis fistula creation is usually performed on the patients who are suffering in their end-stage renal disease and require permanent vascular access to receive their long-term hemodialysis. So it just helps them a little bit along in their end stage of this process. Your C-arm setup, you're going to use pulse and low dose. The surgeon gets the foot pedal, you know you're going to slide it under. We use the other C-arm for that, the specials one that has that digital subtraction mode, and they're going to be injecting water-soluble contrast. So you may start down here in the elbow and move up to the humerus, and a lot of times they travel it through to the chest, right, to evaluate the diameter of it and to check on that. And then the leg would be the same way. So you're just going to follow the contrast up. They're going to look for any impinging areas, any areas of blockage. Usually they blow up that balloon with contrast and really kind of dilate that area and then check it again. And you might see some grafts within here that they may have had previously. The subtraction mode, just remember we talked about subtraction in image production, but it's when you're going to subtract sort of the things that are blocking the blood vessels. And so this one you can clearly see the elbow, the bony areas of the elbow, the humerus, the radius, the ulna. And then in this image, they've been subtracted out. So you can see the vessels more clearly, or the arteries or the veins or whatever their focus is. So they will use the subtraction mode for us. The sinogram is a sinus wound, and it's usually on the surface or underlining area. It could be an abscessed area. It could be have a current infection. There could be discharge or things like that. So use like your precautions and make sure you're being aware of any bodily fluids that could be coming out of this sinus. And then the radiologist is going to place a catheter, and we usually use just those like Foley catheters, and the radiologist will place it inside the sinus, and we're going to inject water-soluble contrast through it and see where it goes. Some of them may be large and on the outside of the body, and they're just not sure where it goes. So the contrast is going to be injected through a catheter, and then they're going to take images, and it's sort of a mystery, and we're going to help the radiologist find it out. All right, I'll be back for part 2.